Hello friends, I am Dr. Mahesh Kumar Lakhe. I am a infectious disease specialist and group lead for hospital infection control at Columbia Asia Hospitals, India, and associate professor of infectious disease at Bharati Vidyapeth, Pune. Uh, it is my pleasure to come here for delivering this lecture on hospital acquired infections, the surveillance and control aspects of it. So, we'll start with our first lecture. First of all, I would like to ask you one simple question. Are our hospitals a safe zone? They introduce risks that are inherent to medical care. So, how dangerous can a healthcare be? So, less than one death per 1 lakh encounters with nuclear power, European railroads, scheduled airlines. There's one death in less than 1 lakh, but more than 1,000 encounters when it is a driving or a chemical manufacturing. But more than one death per 1,000 encounters when there's a bungee jumping. And these are all examples. So basically, hospital acquired infection is killing more people than any of these put together. So it may seem a strange principle to enunciate as the very first requirement in a hospital that it should do sick no harm. So you all remember Florence Nightingale, that primum non nocere, that is first of all we should not do any harm to the patient. So how to define these hospital acquired infections? So, definition of hospital acquired or healthcare associated infection by World Health Organization is as follows: an infection occurring in a patient during the process of care in a hospital or a healthcare facility, which was not present or incubating at the time of admission. This includes infections acquired in the hospital but appearing after discharge, and also occupational infections among the staff of the facility or healthcare workers. So, prevalence of healthcare associated infection in developed countries, it is around 7 to 8%, especially in the Europe. When it comes to developing nations, the prevalence of HI is pretty more high, and it is not uniform as we see in European countries. So, when it comes to India, we do not have much of data, uniform data, but there are few centers in India like CMC Vellore, or it could be All India Institute of Medical Sciences or PGI Chandigarh, or some of the hospitals like Hinduja Hospital. They have their own data they have come up with, but there is no uniform data available. But if you take, there's large variation of these kind of data available. So, incidence of healthcare associated infections in our country, lack of reliable data affects estimates on the burden, and millions worldwide every year. No healthcare facility, no country, no healthcare system in the world is free of this problem. So, developed world it is 5 to 10%, developing nations it is at least 2 times higher and can exceed 25%. So, we do not have data, but it could be a major problem. When it comes to intensive care units, ICUs, different ICUs, it could be up to 30%, and it could attribute to almost 50% or 44 to 50% of mortality of any patients who is admitted in the ICUs. So, 2 in 5 patients get infected in the hospital. There is a study which was published in TOI, if you remember, and that is from one of the hospitals in Chennai. Similarly, there are some publications even in the north, especially the one which is published in from the PGI Chandigarh Hospital. So, they have a predominant risk of hospital acquired infections, and the cost or expenditure to the tune of 6 to 7,000 crore annually, which could be saved if we save this hospital acquired infections. So, HAIs remain one of the main complications suffered by the patients today in the hospital environment. Healthcare associated infections are costly in terms of human sufferings and financial costs. So, once we know the impact of nosocomial infection as a financial burden, and the attributable mortality is up to 40%. Prolonged length of stay in the hospital is from anywhere from 5 days to 25 days, and increase of cost is 5,000 to 40,000 crore rupees. So, it is huge amount of burden. So, the cost of healthcare associated infection, both humans as well as financially. So, if you see this chart, morbidity and mortality, hospital expenditure and loss of man days, lost man days. When it comes to patient, environment, hospital, these are the three important factors are getting affected by these HAIs. And nowadays you might have heard about these resistant bugs or so-called super bugs, which are actually predominantly seen as a hospital acquired infections, and the cost to treat these kind of superbugs or multi-drug or pan-drug resistant infections causing hospital acquired infections like VAP, CA, UTI, the cost is huge. And for example, I have a patient who's got hospitalized for say dialysis, and if that patient develops a dialysis catheter associated infection, which develops further into infective endocarditis or a vertebral osteomyelitis, and the cost to treat those kind of infections like surgeries and antibiotics and other procedures, it is around 10 to 12 lakhs rupees. And this is a current example which I have seen recently in one of the hospitals. So HAIs, they are leading cause of death, 53.9 million from all causes worldwide. So if you see infectious disease, it is almost 50%, that is 40%, 48%, almost half of the total number of deaths. The cost of healthcare associated infection in both humans as well as it is again financial burden. So what's the risk factor for HI? The most important risk factor for HI is the patient being in the hospital, that is hospital environment. So it could be the presence of devices like catheters in the urinary tract, or catheters in the bloodstream like central venous catheters, or even phlebitis caused by IV cannulas. The most difficult situations come when the poor hand hygiene is there. Then clinical practices, different clinical practices like procedures, they are also make patient at risk of developing HAI. And unclean environment is again one of the important factor. And there are some host factors as well, like patient who are elderly or aged people who get hospitalized, for example, suppose for a bypass surgery. The person is frail, he is already 65 plus, and he has got other comorbidities, or she has got other comorbidities like diabetes, hypertension, asthma. All of them taken together make them at higher risk of developing hospital acquired infections, for the simple reason that they are sort of immune paralyzed patients. Underlying comorbidity, as we discussed. Apart from that, immune status of the patient, if the patient is on steroids for example, for getting treatment for a rheumatoid arthritis or asthma, that patient already is immunocompromised. So once he enters into this kind of environment in the hospital, he is at risk of developing HAIs. Apart from that, important one is nutritional status of the patient. If the patient is undernourished or malnourished, or even obese or high BMI patients, they are at higher risk of developing HAIs when it comes to, for example, SSIs and so on and so forth. So there are different types of HAIs. For example, catheter associated urinary tract infection, more frequently we term it as COTI. Then apart from that, central line related bloodstream infection. There are pneumonias, device associated pneumonias like ventilator associated pneumonia, ventilator associated tracheobronchitis, urinary tract infections, bloodstream infections, surgical site infections, and there are some others like hospital acquired pneumonias and phlebitis and needle stick injuries. So can we make a delivery of healthcare process safer? I think yes. So robust infection prevention and control. So our aim to understand how to prevent and control these infections. So safety of patients, safety of staff, and safety of the environment, and that is how the quality of care improves. So do you know what your hospital's infection rates are? You may want to ask your doctor or a hospital representative, what are you doing to get it to zero? So the most important aspect of this, how you are going to get it to zero, is surveillance. So that is the first step, I think, when it comes to know exactly what is the number of cases are affected by HAIs in your center. So what is surveillance? System that starts and ends with communication, action, and information loop or cycle. You have to collect the data, that is data collection, then collection and recording or reporting of the data, and then a person will analyze and interpret the data and dissemination of the data to end users. And again the cycle continues. So, this is the process what we usually term it as surveillance. So, what is the purpose of surveillance? So, the most important or the basic purpose of surveillance program is for the betterment of the patients or better patient outcomes. So, the objectives of surveillance, like first of all baseline data, establishing endemic baseline rates, identifying outbreaks, identifying risk factors, then bring about the change, like then you discuss all these things, share the data with your end users, and bring about the change by persuading medical personnel, evaluate control measures and reducing the infection rates. And you have to sustain these quality indicators, satisfying the regulators, document quality of the care and compare hospitals' HIR rates. So, who should do the surveillance? Is it all hospitals, all departments, all specialties or other health institutions? I think it is the job of everyone nowadays. Every hospital is every hospital wants to know their HAIs and they want to present their data and they want to control this for the betterment of the patient. And what is the end point of HI surveillance? That is the data that demonstrate HI prevention. So, once you know that this is the rate of HAI in my hospital, so what I am going to do is I am going to talk to the end users and I am going to make a change in their behavior or the practice patterns, which is going to decrease this HAI prevention and which can be sort of positively disseminated among them, and they can be implemented in the same fashion with other specialties or other doctors as well. So, report and use surveillance information, have a clear plan for distributing the surveillance information, provide feedback to the clinicians, present surveillance findings using graphs and easy to read tables, and reporting should be timely. So, that is very important, real time reporting is important. Otherwise, you wait for at 1 year, and at the end of 1 year you are going to disseminate the data that I had this kind of HI rate in the 6 months back or 8 months back. That is not going to make much difference. So, it should be a real time process. So, there are different benchmarks or cutoffs. Usually by and large CDC cutoffs or Center for Disease Control gives cutoffs for different HAIs that can be used as benchmark in your institute. Or for developing nations, there is something called as International Nosocomial Infection Control Consortium. So, they collect the data from countries like India, Brazil, South Africa, and some of the African countries and Southeast Asian countries, and then they benchmark it. So, you can use that as well, one of the benchmarks to control or to present it in your institute, or you can have your own benchmarking as well. So, different hospital acquired infections and device associated infections, for example, we are going to discuss today. They could be localized or systemic conditions resulting from an adverse reaction to the presence of infectious agents or toxins, and that was not present on admission. So, all elements of CDC and NHS, that is a National Health Surveillance program, site specific infections criteria for first present together on the 3rd hospital day. So, I am going to discuss this in detail when we are going to see each HAI in detail. So, remember that the power of surveillance is in sharing the findings with those who need to know and who can act on the findings to improve the safety of the patient. So, a patient safety component basic structure, this is the basic structure of patient safety component, and these are some of the important HAIs which we are going to discuss in further course. Like CL, ABSI, CLABSI, VAP, COTI, and phlebitis. So, I am going to switch to my first HAI. First of all, I am going to discuss about catheter associated urine tract infection. So, the outline of this important talk is what is the impact of CAUTI and HSS prevention targets, pathogenesis, epidemiology, then preventive strategies. So, there are some core preventive strategies and there are some supplemental strategies, and measurement means there are different processes and outcomes. So, impact of CAUTI or COTRI. This is most common type of healthcare associated infection. So, more than 30% of hospital acquired infections reported to national registry are because of the CAUTI. So, it is estimated that more than 560,000 nosocomial UTIs annually reported in US. Similarly, in our setup, in Indian setup, in any hospital in India, the story is not different. In fact, we might be having more CAUTI infections. So, increased mortality and morbidity. So, estimated 13,000 attributable deaths annually in US. So, in one of the studies from down south in CMC, they have seen that attributable mortality is up to the tune of 27,000. So, almost double. Leading cause of secondary bloodstream infection with mortality around 10%. So, when patients develops a CAUTI and secondary to it they developed a bloodstream infection, which many times leads to death, because you might be aware of these organisms whatever we are getting, like for example, say an E. coli infection, which is pan drug resistant. Nowadays we see at least 25 to 30% of germs which are pan drug resistant. So, they are not sensitive to any of the medications, and if the patient develops a secondary bloodstream infection because of the CAUTI, just imagine the problem with treating these kind of patients. So, you have to just use one of the highest sort of antibiotics like carbapenems along with colistin, and the cost of which per day is more than 15,000 rupees, and that too you are not sure whether that is going to work or not, because the germs have become resistant. Excess length of stay. So, each CAUTI case, if you count, it may extend the length of stay of the patient anywhere from 2 days to 4 days or even more, like 7 days. And increased cost, that is 0.4 to 0.5 billion dollars per year nationally in US. So, unnecessary antimicrobial use, this is one of the most dreaded complication I feel personally because of the hospital acquired infection, because you pump in a lot of antibiotics to treat these patients, and so your antibiotic stewardship program in your hospital goes for a toss, which again leads to further drug resistant bugs. So, urinary catheter use, 15 to 25% of hospitalized patients are on catheter. You might be aware of that. 5 to 10% of long nursing home residents, they are also on long term catheters, and they are often placed for inappropriate indications. You might have seen, for example, a patient comes for a say a spine surgery, and just for the convenience he has been during the operation theatre they put the urinary catheter. But later on, doctors or the residents, nurses who are treating this kind of patient, they forget that the catheter is already there, and they don't remind the doctor whether this catheter is required on the PO post-operative day 1, 2, 3 and so forth, and that remains there. And it is one of the risk factor for developing CAUTI. Physicians frequently are unaware, that is what we discussed. In a recent survey of US hospital, more than 50% did not monitor which patient is catheterized. Can you imagine this? This is horrible. 75% did not monitor duration and or discontinuation of the catheter, and it leads to increased rate of CAUTI. So, symptomatic urinary tract infection per 1000 urinary catheter days as measured in NHSN definitions. A 5-year prevention target in US they have decided for 25% decrease from the baseline. In our hospital where I work basically, so we have sort of reduced the rate to almost 37% in a given year. So, first of all, I would like to show you this definition of CAUTI, catheter-associated UTI or CAUTI, where an indwelling urinary catheter was in place for more than 2 calendar days, that is 48 hours on the date of event, with day of device placement being day 1. So, for example, if you place a device on day 1, that is on 1st of say September, and you develop symptoms, or the patient develops symptoms on 3rd. So, basically 2 calendar days, and then you may think of the present scenario as an CAUTI. And an indwelling urinary catheter was in place on the date of event or the day before. If an indwelling urinary catheter was in place for more than 2 calendar days and then removed, UTI criteria must be fully met on the day of discontinuation or the next day. So, for example, if you had a catheter on first and patient was okay on second and third, and on third you have removed the catheter, but on the fourth patient developed urinary tract infection. So, that UTI is attributable to the catheter which was just removed. So, once you understand this definition, then the pathogens of CAUTI. This the lower urinary tract infection is full of germs. There are a lot of bacteria which are just colonized there, and it is a unsterile or non-sterile site. And when you actually pushing a catheter inside, you are actually disturbing all the milieu and flora there, and those germs are actually going to make a kind of biofilm over that catheter, and it is going to make the situation worse by disrupting the anatomy of the ureter, and which leads to a urinary tract infection. So, source of microorganism may be endogenous, that is meatal, rectal or vaginal colonization, or exogenous, usually via contaminated hands. So, if you see our hands, they are the main source of spreading these kind of infections or causing this kind of infection for a particular patient, and usually via contaminated hands of healthcare personnel during catheter insertion or manipulation of the collecting system. So, if you see this schematic diagram here, you will see. So, early at the insertion, the extraluminal colonization, and late by capillary action here, and intraluminally break in the closed drainage and contamination of the collecting bag and urine. And another important aspect which I have found in many hospitals is the urinary bag is actually kept on patients abdomen, or where the patient is actually lying down and being shifted to OT or being shifted to a radiology for a imaging study or for a procedure, and whatever urine was being collected into the bag, actually it is going as a backflow. So, that is a strict no, and it should be avoided. So, formation of biofilm by urinary pathogens common on the surface of the catheters and collecting system. Bacteria within biofilms are resistant to antimicrobials and host defense. Some novel strategies in the CAUTI prevention have targeted these biofilms. So, these are the definitions what we have seen, and you remember that you have to count only symptomatic urinary tract infections, that is SUTI only, and not asymptomatic bacteriuria. So, many times patient is asymptomatic, meaning they do not have any urinary frequency, dysuria, back pain, lower abdominal pain, or fever, chills, or raise in the blood counts. So, none of them, and you just do the urine routine microscopy, and you find that there is a bacteria there, and you culture it, and there is bacterial growth. So, these asymptomatic bacteriurias should not be counted in CAUTI for surveillance, and there is different significance to these asymptomatic bacteriuria. So, evidence based risk factors for CAUTI. So, once we define CAUTI, and once we know how to keep the record, we should know what is symptomatic UTI and bacteriuria. Symptomatic UTI, the biggest risk factors are prolonged catheterization. So, main modifiable risk factor is this. So, you can cut down on or cut short the duration of catheterization. The next one is female sex. So, a female having catheter is at higher risk of developing CAUTI for the simple reason because their length of ureter is shorter as compared to the male counterparts. And older the patient, the higher the chances of CAUTI, and impaired immunity is again one of the important risk factors. So, for bacteriuria, it is a disconnection of the drainage system, lower professional training inserter. So, somebody who just joined and they are not trained and they are just putting it. So, it is a high risk for bacteriuria. Placement of catheter outside the operative room. So, in operative room, usually the things are in well control and they put the catheter. Incontinence is one of the risk factor for bacteria. Diabetes, meatal colonization, renal dysfunction, orthopedic and neurology services where they do the catheterization. I don't know, for some reason like they are undertrained or they are in hurry or they consider this procedure as very less important or meager. That is one of the risk factor for bacteriuria. So, once we know the risk factor, how to prevent it, the most important aspects are core strategies and there are some supplemental strategies. The core strategies are insert catheters only for appropriate indication. The most important thing, if you just know that if this patient requires a catheterization and this is the time he is going to require a catheterization, almost you can cut down on 50% of the CAUTI. Leave catheters in place only as long as needed. So, daily reminders. In my hospital where I was working, what we have done is our infection controllers used to send SMSs to the consultants, especially those patients who are on catheters, asking whether this patient requires catheterization daily. And believe me, almost 8 out of 10 times they said, yeah, of course, I forgot to check that. Please, you can remove the catheter. Ensure that only properly trained persons insert and maintain the catheters. So, basically you have to train some of the nurses who are working in those particular areas or especially doctors who newly join the institute to insert the catheter. Insert the catheter using aseptic techniques and sterile equipments. Most important means you need to clean with the betadine and properly scrub it below the umbilicus and above the mid thighs before inserting the catheter. Following aseptic insertions, maintain a closed drainage system. This is again very important. So, maintaining a closed drainage system is again one of the important point in one of our NABH surveillance programs. So, maintain unobstructed urine flow, that is very important. So, many times you have seen like clamping the catheter and checking whether the patient has got sensation or not. That method in fact makes the patient more susceptible for CAUTI. So, if you think that this patient doesn't require a catheter, you just remove it. Of course, he or she is going to have sensation and they are going to pass urine. If they don't, then we can go for the second catheterization, but 9 out of 10 times it just that is the method one should use. Hand hygiene and standard precaution, this is the most important. If you ask me, I would have kept it as a first strategy because dirty hands are the culprits. So, specific recommendations, insert catheters only for appropriate indications. If you see there is a list of these indications, you can just go through it. And insert catheters only for appropriate indications. Minimize use in all patients, particularly those at higher risk of CAUTI and mortality, like women, elderly patients, impaired immunity, diabetics, especially in our setting. Avoid use of management of incontinence and use catheters in operative patients only as necessary. And the other specific recommendation, leave catheters in place only as long as needed. So, remove catheters ASAP, that is as soon as possible. Perform hand hygiene before and after insertion. Use sterile gloves, drapes, sponges, antiseptic or sterile solutions for periurethral cleaning, single use packet of lubricant jelly, and properly secure the catheters. If breaks in the aseptic techniques, disconnection or leakage occurs, replace the catheter and collecting system using aseptic technique and sterile equipments. So, consider system with pre-connected sealed catheter. Nowadays they are available, and obtain urine samples aseptically, because many times if you see if you ask a nurse to collect the sample for urine routine or urine culture, they many times are busy working with their patients, other stuffs, and they ask one of the nurse aide to collect the sample. And I have seen, believe me, they take urine from the bag or from the pot. So if you send that kind of urine to lab, they are going to grow all these colonized germs which are colonized over those urinary bags and pots, and they are very resistant, and patient is being wrongly identified as bacteriuric patients, and many times they end up receiving a lot of antibiotics. So there are catheters with those blue ports on them, where they are self collapsible, and there you can actually put a sterile needle, take the sample, and put it into the container, sterile container. So maintain unobstructed urine flow. This is again very important part of it. Implement quality improvement programs to enhance the appropriate use of indwelling catheters and reduce risk of CUTI. Examples like alerts or remands. So that's what we have tried in our hospital. Stop orders, and stop orders are very important. Protocols for nurse directed removal of unnecessary catheters. So if you know that a particular nurse who is working in a hospital and she knows the culture and she has got good rapport with the consultants, then they can actually be trained as a catheter nurse, and they can be empowered to decide whether the particular patient needs a catheter or not, and it works. Guidelines and algorithmic approach for appropriate perioperative catheter management should be followed. So consideration of alternative to indwelling urinary catheters should be kept in mind, like condom catheters. And use of antimicrobial antiseptic impregnated catheters can be thought of, but cost is a big issue there. Use of portable ultrasound devices for assessing the urine volume to reduce the unnecessary catheterization. So many times you think that patient is not passing urine, and actually there is no urine in the urinary bladder, and still you think that putting a catheter. So this method can be used. So intermittent catheterization should be considered wherever applicable. Then external catheters, it should be considered for cooperative male patients without obstruction or urinary retention. Then supplemental strategies, rationale is fewer catheterization is equal to lower risk of UTI. So inpatient rehabilitation centers and fewer there you can actually try this fewer catheterization per day, but no reported difference in the UTI. And there are some limitations to these studies as well. So consider using, if CUTI rates are not decreasing after implementing the comprehensive strategy, you can apply these supplemental prevention strategies. So to summarize, the supplemental measures or strategies are alternative to indwelling urinary catheterization. You should think of that. Portable ultrasound devices, as we discussed, and antiseptic impregnated catheters. And there are some of the strategies which are not recommended. That is complex urinary drainage system. Means they are very complex. You are confused whether to turn the knob to right or left and all, and they make situations worse. Changing catheters or drainage bags at routine. So previously that was being discussed many times, and people used to just change it every third or fourth day. But in fact that is one of the risk factors to increase the CUTI. Then routine antimicrobial prophylaxis is strictly no, because you might have seen in your orthopedic wards or surgery wards, doctors say that remove the catheter, just give a shot of gentamicin or anamic acid. That is strictly no, that that is not required. In fact that is harmful. Cleaning of periurethral area with antiseptics while catheter is in place, that is again no. So use routine hygienes basically. Irrigation of the bladder with antimicrobials, again not strictly not recommended. Installation of antiseptic or antimicrobial solution into the drainage bags, that is also not going to save patients from CUTI. Maybe it can just wipe off all the germs and from the urinary bag. And routine screening for asymptomatic bacteria, again it is not indicated. So whenever your patient is symptomatic, then only you should collect the urine with antiseptic or aseptic precautions, and then do the culture and further tests. So, compliance with hand hygiene, compliance with educational program, compliance with documentation of catheter insertion and removal, and compliance with documentation of indications for catheter replacement. These are very important to curtail the CAUTI rates in your hospital. So, this is one of the NHS and device associated module. So, this can be used, and there are some NABH modules also which can be used to collect the samples and patients data. And maybe we can go ahead with our next important HAI,